Your immune system is basically your own personal microscopic army. It's on duty 24/7, fighting off all sorts of invaders. But what happens when that army gets confused? What if some trigger, maybe a past infection, maybe something we don't even understand yet, causes it to completely lose its bearings and it can't tell friend from foe? What happens when it declares a full-on civil war on your own body? Well, that's exactly the mystery we're going to dive into today. This right here is the central question behind some of the toughest puzzles in medicine. So today we're going to play detective. We're going to follow the clues in two totally different medical cases, figure out what the internal enemy is, and uncover how two very different problems actually share a surprisingly similar solution. All right, meet our two patients. Now, on the surface, their problems look like they're from different planets. We've got a woman who is suddenly exhausted and jaundiced, and then a young guy who just can't stop bruising. But, believe it or not, they both share the exact same hidden problem. Their own immune system has gone rogue. Okay, so to solve any mystery, you have to start with the evidence, right? For doctors, that means decoding the signals the body is sending, first through symptoms, and then, crucially, through the cold, hard data you get from lab results. And what's so fascinating here is how these two sets of symptoms point to completely different problems inside the blood. I mean, for patient number one, the fatigue, the jaundice, the shortness of breath, that all just screams, hey, we've got a problem with oxygen delivery. But for patient two, all that bruising and bleeding, that is a classic sign of a problem with clotting. And wow, this chart really shows you the crisis for our first patient. Her hemoglobin, that's the protein in red blood cells that carries all the oxygen, is down to a dangerously low 6.8. Now, to put that in perspective, the low end of normal is 12. So she is literally running on half a tank of oxygen, which totally explains that extreme fatigue and shortness of breath. Meanwhile, for our second patient, the emergency is his platelet count. It has absolutely cratered to just 12,000. A healthy person has at least 150,000. Platelets are these tiny little cells that basically plug up holes in our blood vessels. So, without them, you get exactly what he's experiencing, spontaneous bruising and bleeding. So we dig a little deeper, and the lab results for patient one tell a really clear story. First, her body is in complete overdrive, desperately trying to churn out new red blood cells to replace the ones being destroyed. Second, a protein that cleans up the wreckage of those destroyed cells, it's gone. It's been so overworked, it's been used up completely. But the real smoking gun? A positive Coombs test. This is the definitive proof, the thing that says, yep, antibodies are attacking her red blood cells, marking them for destruction. So, with all the clues on the table, we've got the symptoms, the critical lab values, and that smoking gun test. It is time for the big reveal. It's time to finally put a name to this internal enemy that's causing all this chaos. For our 42-year-old female, the diagnosis is autoimmune hemolytic anemia, or AIHA for short. Basically, her immune system is manufacturing these little weapons, antibodies, that are specifically targeting her own red blood cells, the things that carry her oxygen. In short, her body is systematically taking apart its own ability to breathe. And for our 28-year-old male, it's immune thrombocytopenia, or ITP. It's the same fundamental problem, right? An autoimmune attack, but it's got a different target. His immune system is going after his platelets, the cells he needs to stop bleeding. So you see, two totally different targets, but one common enemy, the immune system itself. All right, so we've named the enemies. Now for the big question, how do we fight back? How do doctors launch their first counterattack? I mean, this is the key question, isn't it? One person is losing red blood cells, the other is losing platelets. You'd think that common sense would say they need completely different treatments, right? But here is the big twist in our story. The best first move for both AIHA and ITP is exactly the same: high-dose corticosteroids. Now, I know that seems kind of counterintuitive, but it's because we're not just treating the symptom, we're going after the root cause. And that's the core logic right there. See, the real problem isn't the lack of cells. The problem is an overactive, confused immune system that is actively destroying those cells. So the first step is to just tell that immune system to stand down, and powerful anti-inflammatory steroids are the fastest way to get that message across. But what happens when that first line of defense just isn't enough? In these complex autoimmune diseases, treatment isn't a single magic bullet. Nope. It is a strategic, multi-layered playbook. And this table lays out that playbook perfectly. Steroids are the opening move. If they don't work, doctors move to second-line therapies, like rituximab. That's a smart drug that specifically hunts down the rogue B cells making the harmful antibodies. Now, transfusions, that's just supportive care. It's like giving someone an oxygen mask or patching a leak, but it doesn't fix the engine. And then, for the most stubborn cases, you might consider removing the spleen. Why the spleen? Well, think of it as the body's recycling center, and it's often the main place where these antibody-coated cells get pulled from circulation and destroyed. So what you're seeing here is a really clear, logical escalation of care. You start broad to try and calm the whole system down. If that's not enough, you get more targeted. And if all else fails, you consider a really definitive physical intervention. It's a structured plan designed to regain control. So just by following these two very different patients, we've actually uncovered a fundamental principle in modern medicine, and it's a principle that applies way beyond just these two conditions. And here it is, the big takeaway. Treat the cause, not just the symptom. The low red blood cells in one patient and the low platelets in the other, those were just the consequences. The real disease was the immune system's civil war. And by targeting that war with suppressive therapy, doctors could solve two seemingly unrelated problems with one brilliant strategy. And this brings us to one last, really fascinating question. Autoimmune diseases, things like lupus, rheumatoid arthritis, they're all just variations on this theme of self-attack. So as our ability to precisely dial our immune response up or down gets better and better, are we on the verge of cracking the code for some of our most mysterious and chronic illnesses? What happens when we can finally negotiate a lasting peace in the body's civil war?